and today we're going to talk about a very interesting topic about how hyperandrogenism can really be beyond PCOS. So generally speaking, we have all been tuned to the fact that a lot of patients who come to us are actually having hyperandrogenism, and we start diagnosing with regards to a polycystic ovarian syndrome because 95% cases are like that. But today we'll highlight how we have different aspects of PCOS, hyperandrogenism, which can cause PCOS in that regards, and that becomes important. So we'll try to cover the other organ which is there in terms of hyperandrogenism, and that is adrenals. We will use 4 cases which will highlight the different spectrum as to when we should suspect, how to evaluate, and how there could be a diagnostic confusion in that regards, and this is how we will proceed from there. So I'll start off with an index case, which is a reasonably common scenario, which we would be thinking of in particular situations wherein you have implications in terms of diagnosis and management. So this was a 14-year-old girl with hirsutism, and on that situation, this girl basically had menarche 1 year ago. Periods were happening every 2 months. There was virilization and muscularity, Ferriman-Galway score of 18, and she had a PCO appearance on ultrasound. So she was labeled, quote unquote, as PCOD. Now, Dr. Sain, do you agree with this diagnosis? So if you have anybody who has virilization, who has muscularity, who has significant FGS or a testosterone level which is more than 1.5 nanogram per DL or more than 150 nanogram per 1.5 nanogram per ml or 150 nanogram per DL, you have to start doing imaging. And what we found was a large heterogeneous lesion, which was an adrenal carcinoma. So while we consider that often, if we talk about hyperandrogenism, 85% will be PCOS, there are other possibilities also which we need to be wary about. The most common cause will be 21-hydroxylase deficiency, the non-PCOS cause around 5% cases, tumor around 1% cases, and 7% is idiopathic. So when you say idiopathic hyperandrogenism, what are the possible causes that you're looking at, Dr. Vibha? So they will be secondary causes anyway. So idiopathic would mean, one, there is more sensitivity to the androgen. So there will be more sensitivity there. They are part of PCOS. So when you say PCOS, PCOS is actually functional ovarian hyperandrogenism. That is what PCOS is. So idiopathic may mean that there is a peripheral production of androgens in obesity. That is one scenario, or the sensitivity is more. So these are the important things to remember. So while 85% are PCOS, you have to worry about these 5% of 21-hydroxylase where you have a different therapy, and of course 1% which is very, very significant. So Dr. Naveen, what are the signs that you will think that this is more likely to be a adrenal etiology rather than PCOD in a girl who presented to you with features of hyperandrogenism?
So the sign of red flags and we need to look for, which is in the form of virilization, spliceomegaly, or any voice change and any.
So if you have features of virilization, which basically means voice change, clitoromegaly, muscularity, those things. So these are one big group of signs. This is for any tumor. What else?
An FGS score of.
That is fine. So that is part of severe hyperandrogenism. So early onset is a very important sign. So if you get a history that this girl had pubic hair growth which was there for a long time and now they have increased, then you think of congenital cause becomes important. Child was absolutely normal and now suddenly there is a lot of hyperandrogenism happening around 18 years, 20 years. Think of an adrenal carcinoma. 30, 40 years old, ovarian carcinoma will be there. So timing becomes important. So severe, again we said, soon is something which is there. Of course, if there is a family history, you will look at. What will be the syndromic features of 21-hydroxylase deficiency? So what will point more towards 21-hydroxylase deficiency?
21-hydroxylase is something that in case if it is from birth, if someone is having
so that is soon, severe, syndromic. What are the features of syndromic? What is syndromic for 21-hydroxylase deficiency?
Advanced bone age, which is
so that will be more, so pigmentation. That will be an important factor to look at, pigmentation. If of course salt wasting, you won't be missing. What else? What else clinical clues you will look at? What will you measure on examination in a girl who comes to you with hyperandrogenism? So blood pressure, it could be 11-hydroxylase deficiency. It could be a tumor which is present on that. So generally, as we were talking about delayed puberty in boys, we say, okay, 80% is CDGP. But if you have somebody who is tall, who has pubic hair development, who has a stalled puberty, who has some syndromic features like anosmia, synkinesis, neurological features, think of a secondary cause. 85% of girls who present to you with hyperandrogenism will have PCOS. But if it is very severe, FGS more than 15, or if you have virilization, if it's too soon, like onset before puberty, if you have syndromic features, like you have pigmentation, like you have hypertension, and if there is a family history, think of an alternate cause. And what we are going to do is that we'll have 4 cases which will illustrate these scenarios and go into that in that perspective. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of interactive videos along with other tools for pediatric endocrine training. There are courses available, including fellowship and diploma courses. We run regular grand rounds in the form of a PG lecture series, which happens in the evening on Saturdays. And these grand rounds, which we run here, there are publications which cover the entirety of pediatric endocrinology, our app, and all those things you can access. So in today's grand round, we will have 4 cases which will highlight these scenarios. But before we do that, we will set the background by understanding what really is hyperandrogenism, what is adrenal hyperandrogenism, and then we can apply it in our clinical practice. So we know that 50% of androgen in women and even adolescents come from the ovary, and this is largely regulated via the luteinizing hormone. And this is via production of androstenedione. The remaining 50% comes from the adrenal, which is controlled via the ACTH. So this is a basic philosophy which comes via DHEAS, which gets converted into both androstenedione and testosterone in that perspective. And these all will then get peripherally converted via 17-beta-HSD into testosterone, which will then get activated to dihydro, which is the active form. So half of your androgen is coming from testosterone, from the adrenals. Half is coming from the ovaries. So now if you have an adrenal form of hyperandrogenism, Dr. Sayan, which metabolites will be high on the blood examination? So you will have high testosterone and high DHEAS in a adrenal pathology and a high androstenedione and testosterone in a ovarian pathology. What about androstenedione in adrenals?
Androstenedione is not the primary metabolite of that.
Will it be high? Will it be low? It will be normal.
If DHA is high,
andro will also be high, because if DHEAS is high, andro will be high, DHT, testo, everything will be high. So don't get a notion that if you have high androstenedione and you have not looked into DHEAS, this is not adrenal. So message is DHEAS elevation is more specific. Androstenedione elevation is not specific from ovarian, because it will also come from the adrenal. So DHEAS is the best marker in terms of that. When you assess DHEAS, Dr. Vibha, what precautions will you take? What time the sample should be taken? Why? It is sulfated. So DHEAS is sulfated, so therefore it is not affected by diurnal rhythm. You can take it any time of the day, as against many of the other adrenal hormones which you have to take on a specific notification in that regards. So now in hyperandrogenism, we said you can have physiological causes, but within pathology, ovarian is by far the most common, followed by adrenal. So we are focusing today entirely on adrenal. We'll be talking about steroidogenic defects, we'll be talking about tumors, and all those scenarios will come up. So we need to understand about adrenal steroidogenesis a bit. So we all know that the initial pathway is common, conversion of cholesterol into deprogesterone using star, side chain cleavage, and 3-beta-HSD. This is then converted via 21-hydroxylase, 11-hydroxylase, and then other enzymes into different forms, converted into, of course, cortisol, aldosterone, and DHEA, which is then converted into DHEAS and then gets activated. So defects in any of these may have a situation in which you have cortisol deficiency and you have secondary increased ACTH production causing hyperandrogenism. So Dr. Naveen, which all enzyme defects out of these will cause hyperandrogenism?
The hyperandrogenism will be found in 21 hydroxylase.
So if you have 21 hydroxylase deficiency, of course, you will have high along with salt wasting, or if the levels are fine, you will have a normal salt status, but you will have hyperandrogenism. Second
will be the 11 hydroxylase.
So if you have 11 hydroxylase, you will have mineralocorticoid excess, you will have hypertension, hypokalemia, alkalosis. Along with that, you will have virilization. What else?
And third will be 3 beta HSD because of peripheral conversion.
So if you have a 3 beta HSD problem, you will have peripheral conversion, you will have milder level of hyperandrogenism. So they will be not, they may actually have virilization, but they will not have a complete Prader 4, Prader 5 staging because it's peripheral conversion. Any other defect can cause this? So these defects will also have an effect because they are involved in conversion of the cortisol and DHEA to DHEAS. That is important. And if you have free DHEA, it is going to be converted more. If it becomes DHEAS, it is stored and you don't have a rapid conversion from that perspective. So if you have a problem in the sulfonyl transferase or the H6B6, you will have a problem. So 3 beta HSD defect, if you give ACTH, you will have a very, very high level of DHEAS. I said DHEAS is a specific marker of adrenal etiology. DHEAS more than 700. Think of a tumor / 3 beta HSD deficiency. 400 to 700 more like a FAH picture. Now you also need to understand that you need to take all these levels together. So if you say DHEAS is high, and testosterone is high, because of a CAH, then your 17-OHP should also be high. You can't have a lowish 17-OHP or low normal 17-OHP and a very high DHEAS because these are all distal pathways. First thing you need to understand what is high. So DHEAS will be very high here and 17-hydroxypregnenolone levels will be very high. Now 21-hydroxylase, we all know 17-OHP will be high, and if you give a ACTH stimulation, the level will go further high. 11 DOC levels will go high in that scenario. If you have a sulfonyl transferase defect, the DHEAS is there, it is not getting sulfated. So it is going to be converted more into androgens, and this is going to cause more problem in that regards. If you have a 11 beta HSD1 defect, what will happen? We all know about 11 beta HSD2 defect. What happens in 11 beta HSD2?
Functional cortisol deficiency, ACTH stimulation, increasing androgens.
So this is the 11 beta HSD1 defect in which cortisol is not getting produced from cortisol. So you will have cortisol deficiency and you will have high ACTH and you will have DHEAS which will be produced in that regards. All these cases will have a common scenario of high ACTH causing pigmentation. So pigmentation becomes an important thing to look at in any girl who comes to you with hyperandrogenism. Can you have non-CAH causes of hyperandrogenism where you have pigmentation? So there is some other cause which is not congenital adrenal hyperplasia, but the girl is pigmented. ACTH dependent Cushing syndrome. But there the ACTH is not very high, so there will be mildish pigmentation, not like CAH where you may have severe pigmentation in that scenario. So these will be the scenario to look at and go for. So basically I discussed non-classical 3 beta HSD. So we are talking about non-classical forms. Classical forms will present to you with atypical genitalia, disorder of sexual development right at birth. So non-classical 3 beta HSD, very high 17-hydroxypregnenolone. But remember, biochemical tests are not foolproof of having a particular enzyme defect. The full proof is genetic test. And as Sayan had presented nicely in our Advanced Pediatric Endocrine Symposium, there are scenarios in which you have very high levels of 17-hydroxypregnenolone, but they turn out to be FAH, functional adrenal hyperandrogenism, but genetic test is normal. Non-classical 21 hydroxylase deficiency is also self-limiting. 17-OHP will be high. Now, when you say non-classical 21 hydroxylase deficiency, Dr. Naveen, what is the usual presentation in that scenario?
They usually present with features of hyperandrogenism, polycystic ovarian disease, oligomenorrhea, and
so what will be the severity in that case?
The severity is usually between 8 to 15 of just score, which is not associated with virilization. So
when you have somebody who has got voice change, somebody who's got muscularity, somebody who's got clitoromegaly, you cannot and should not label that child as non-classical CAH. So many times you will see, and this is interesting, when you have a tumor, it will actually be producing 17-OHP also as part of the deranged steroidogenesis. If your 17-OHP is mildly elevated and you say, okay, this is non-classical CAH, but that non-classical CAH will not have a testosterone more than 200. It cannot have. It will be like 60, 80, something like that. It will not have virilization. It will not have clitoromegaly. So this point is important, that always correlate 17-OHP level to the level of elevation, which is of testosterone. Non-classical 11 will have milder disorder, and this will cause more like a hypertension will be there, but again it can be mild. SULT2A1 deficiency, again it's premature pubarchy, not like a typical virilization, and then again conversion, you will get a diagnosis in that regards. Now we all know that CAH will cause hyperandrogenism, but what are the specific mechanisms by which CAH will cause hyperandrogenism? The first mechanism we of course know is that adrenals are producing a lot of DHEAs that is causing that. But remember, this will also get converted into testosterone, and this testosterone will go to the ovaries and hyperandrogenism begets hyperandrogenism. So if you have high testosterone, the ovary becomes producing more androgen. So this is the second mechanism which happens. What are the other mechanisms by which CAH causes hyperandrogenism, Dr. Sayan?
There are certainly adrenal rests in the ovaries that can also do, and prolonged hyperandrogenism will cause a reset LH axis. So that will also drive the production.
So you may have adrenal rests which are resting in the ovaries, and if you have uncontrolled CAH, they can start producing androgens there. What we have talked about also is very important, is a prenatal exposure. So normally progesterone inhibits LH secretion. But if you have prenatal hyperandrogenism, this inhibition goes off. So your hyper LH state will be there in CAH. So if you have CAH and you are controlling your 17-OHP well, still you can have hyperandrogenism because you have this antenatal phenomena which is working, and ovaries may have gone into hyperdrive because they already have a high level of testosterone exposure which is there in that scenario, and that becomes important in that regard. Now, adrenal tumor we talked about is usually carcinoma. Now, this is important. Normally, when we say if you have a virilizing adrenal tumor, we always say carcinoma. But this may get confusing when we discuss our cases today. It is a rapidly progressive, so it can't be 8-year history, 9-year history. It has to be within a year or so. You will get a history, and management is very difficult. Poor prognosis, surgery, mitotane, these things can be considered. So now once you know that this is hyperandrogenism, you have significant elevation of testosterone beyond 55, or you have FGH which is more than 15 or 8 to 15 with high androgens, you know it is not related to puberty, then you think of a pathological cause. The first question is it ovarian or is it adrenal? So to answer that question, we have already discussed that you look at, if it's ovarian, you will have a normal DHEAs and a high androstenedione. Adrenal, remember, andro can still be high. So don't get fooled that your andro is high, it becomes ovarian. It can still be adrenal in that regards. The most important, the gold standard test of differentiating adrenal versus ovarian etiology is DEXA suppression. So if you give dexamethasone and your androgen levels come down, it means it is adrenal, functional adrenal, or CAH. If you give DEXA and your androgen levels do not come down, it can be an autonomous adrenal producing tumor, or it could be a ovarian etiology. So dexamethasone suppression is an ideal way to distinguish between the two scenarios. And if you go the other way around, if you give GnRH and the level increases, this is ovarian and not a adrenal origin in that regards. So what really is DAST? DAST is basically a dexamethasone androgen suppression test. You give dexamethasone. Typically, we use the same as low-dose DEXA, 0.5 milligram, 6 hourly for 8 doses. There is also a shorter version in which give you 1 dose and then look at it in the evening, because in the evening, the levels are anyway low. So you may be able to get it, but usually we should follow this long DAST. And in that scenario, if you give dexamethasone, ACTH should come down, cortisol should come down below 40, DHEA should come down below 40 as well, and testosterone should also become low. So a normal response to DAST is a low cortisol, low DHEAs, and low testosterone. But if suppose you have an autonomous problem or an ovarian problem, in that scenario, this testosterone will not come down. Suppose you see that the cortisol is also high and testosterone is also high. What does it mean? And imaging is normal. You have a patient who has got a DEXA suppression in which cortisol is also high and your testo is also high, but there is no anything else more common. So it is unusually to be a topic, but if the patient has not taken the tablet, if the patient is on an enzyme stimulant, which drugs can interfere, cause a false negative? So if you are on phenytoin, phenobarbital, any of those drugs will cause inactivation of dexamethasone. That also, all those things will have a issue in that perspective. So you need to be aware about in that perspective. So if you have an adrenal tumor, these responses will not be there. So if you have suppressed testo, suppressed cortisol, this is CAH or FAH. This is what you can consider. If testo is not suppressed, but cortisol is suppressed, this is ovarian. If both are not suppressed, think of Cushing's, which is primarily there from the, as you said, a macroadenoma and all those things really can do that. Cortisol resistance and poor compliance. Adrenal tumor also will be in the same scenario in that perspective. So ACTH stimulation test can be required, especially when you're thinking of CAH, but this is mainly for non-classical CAH. In classical CAH, your 17 OHP should be very high. So if a 17 OHP is more than 1500, it goes in favor of non-classical 21-hydroxyl deficiency. Then as I discussed, 17-hydroxypregnenolone increase suggests 3-beta-HSD and 11-DOC increase suggests 11-hydroxylase deficiency in that scenario. Always measure cortisol levels before you do further evaluation. So suppose your cortisol is less than 138, this could be an exogenous steroid. And we have seen so many cases of exogenous. How are they different from the cases that we are discussing today, Sayan? Your first case was the exogenous one, whom you were thinking of PCOS as a possibility.
There is typical telltale signs of Cushing's syndrome.
So they will have mild hirsutism. They will have more of myopathy, more of Cushingoid habitus, more of hypertension, but they will not have virilization. So this is very easy to exclude. So the cases we are discussing today are all which presented with a significant hyperandrogenism with quote-unquote virilization, clitoromegaly, which was relevant. So that is important to remember. 138 to 276, nothing to be done. More than 376, you have to work up for Cushing syndrome. DHEA, as discussed, can be done any time of the day. It is basically an immunoassay. Levels which are more than 400 are significant. More than 700 are tumor / 3-beta-HSD. But as Sayan will show, sometimes you can have a higher level in FAH also. What exactly is FAH, functional adrenal hyperandrogenism?
Adrenal tissues are more hyper responsive to the.
So they are, without any disease, they are producing more. So they are hyper responsive to ACTH. That is what it is, FAH. So if I finally summarize, if you have hyperandrogenism and you know there is significant hyperandrogenism and you find virilization, you look at DHEAs above 700, do a adrenal imaging.
This is a very interesting case. A 28-year-old female came to us with a complaint of increased hair growth for 6 years. And she had no periods for 6 years. And she told us that she was asymptomatic with no complaint 6 years back. And suddenly their body hair growth started increasing. They were dark and pigmented over the face, upper lip, chin, back, abdomen. And there was a gradual increase. She had menarche at the age of 13 years of age. Her periods were completely regular, but gradually they became irregular and then stopped. She also gave the history of increased pigmentation of knuckles, lips, and forehead. She had also noticed that there is some deepening of voice, increase in muscularity, and loss of hair from the frontal and the temporal region.
So what are the cutaneous manifestations of hyperandrogenism?
So acne, and this hidradenitis suppurativa, and this baldness. So
she has baldness, she has hair growth, but you don't have any history of acne.
Acne, and there was no history. She took some homeopathic medications for these complaints, but there was no relief. There is no history of any weight gain, difficulty in combing. This was asked for ruling out the proximal myopathy and type 2 diabetes mellitus and the strias. There was no history of any early puberty, no history of hypothyroidism, and any galactoria or any history of drug intake. No past history of any recurrent hospital admission, and no history of any atypical genitalia since birth, and no similar complaint in the family, and no history of consanguineous marriage, and no history of any sibling death. In the general examination, her BP was normal. This BMI was 20 kilogram per meter square. There was no acanthosis. FGS was 21. And there was no goiter, there was no stria, and there was a clitoromegaly of 3 centimeter, and the Prader stage was 1.
So now, if I look at here, do you think that this girl has any sort of a red flags that you should be worried about?
Definitely, sir. She has.
What other thing you're looking at?
So in the history, she had a voice changing. She has a this increase in the muscularity. She has this FGS, this increased growth, body hair growth, FGS 21.
Definitely, it is severe.
Definitely, it
Because
is
there is
severe.
clitoromegaly.
Yes, sir.
There is a FGS which is 21.
One.
That is suggesting it's a severe form. So
Yes.
you can't just say this is your garden variety PCOS. This is something more which is there. Now, within the etiology, now, if we go in terms of our algorithmic workup, you said, first of all, can this be physiological versus pathological? Is it physiological?
So this is pathological because this is beyond the pubertal
So,
range.
generally, when we say 5 years post-menarche is the maximum when the physiological causes can be. So this is not physiological. This is pathological.
Yes, sir.
Now, within pathological, we talked about broadly ovarian, adrenal, and then peripheral and drugs. So you don't have any drugs implications.
No,
so
sir.
now it's ovarian versus adrenal. So can you make a guess on your clinical examination what it could be more likely to be?
So there is there is a history of viralization, and there is a history of viralization. This is more likely the source. Pathogenesis is more of the adrenal cause.
So which ovarian cause causes virilization, Dr. Sam?
Ovarian cause will be a history of long-standing PCOS transforming into sarcoma, or it can be, as you said, a 30 to 40-year-old perimenopausal female having a granulosa cell tumor.
Adenoblastoma
And
or a virilizing
blastoma.
tumor. So your point is you cannot just say that because she has virilization, she cannot have an ovarian cause. In fact, if you now look at history, what science said, somebody had a long-standing hyperandrogenism, and ovaries suddenly start producing a huge amount that becomes hypertrichosis. That is one possibility. Now, if you say now that this is an adrenal lesion, 8-year history, what is the most likely diagnosis you're dealing with? Within adrenal?
If there is, this is a gradual progression, so it is less likely to be a carcinoma. This is more likely to be something dealing with the steroidogenic defect. Like
so, why did she not have clitoromegaly at birth?
so, it
If you think it is a 21 hydroxyl deficiency, the classic
so it
form.
could be a non-classic form, or it could be a 3 beta HSD in which
So non-classic form, as I said, will not have clitoromegaly.
it could be a milder
normal.
form. Yes, sir.
And if you say simple virilizing, can simple virilizing have a normal genitalia only?
No, sir.
Very less like
So if you have the exposure of antigen will be antenatal.
Yeah.
If you have antenatal hyperandrogenism in somebody who's adrenal, so you have to explain. If your androgens are now very high, why were they not high antenatally? So if it is CAH, it has to be right from birth. That is an important thing to remember. And if you have a classic form of CAH and your androgens now are causing clitoromegaly, they should also have caused at that time. And if they were high at that time, they will also cause
Salt pasting?
no
No.
labioscopic. So it
Labioscopic.
is unusual for a classic form to just present the clitoromegaly. So what I'm trying to say that if you take your history carefully, which you've done very well, you can really say, okay, this is not PCOS, this is not physiological form. CAH, very unlikely because she now has clitoromegaly. There is something which new had happened. Don't you think that there is something new had happened?
Yes, sir.
Yes, sir. Something new.
So because this has to be an acquired form, it is not a typical congenital form, or They were the congenital form, which has now led into a suddenly something big, which has started producing steam. So this is classically going more in terms of acquired.
Something pigmented, ACTH dependent.
Yes, sir.
So this is other possibility of
Is
ACTH dependent
dependent
acquired form. But
Quiet form.
what is unusual for that?
So
If it is ACTH dependent, will it only produce androgen?
androgen, there is a no Cushing-White feature.
Zero features of Cushing.
Cushing-White.
Clitoromegaly, you're getting that level of androgen, so it is unlikely to be because of a single ACTH cause, which is a Cushing's disease. Ectopic. Now, if you talk about ectopic ACTH, it is a very rapid course. You can't have 8-year course. You will have a rapid course with hypertension, hypokalemia, alkalosis, maybe some villanization, but clitoromegaly of the centimeter again becomes important. So if adrenal is producing enough DHEAS to cause clitoromegaly, it should also be producing enough cortisol and Cushing syndrome to cause much more Cushing-White features. So this is also unlikely in that situation.
So can clitoromegaly be missed for a normal?
Yes,
at birth?
if
So that is one point.
Even doctors
Simple-
do miss it at times.
But then the point is, why would anybody with classic form, see, non-classical cannot have clitoromegaly.
Simple way.
If you have clitoromegaly at birth, unlikely that you don't have any fusion. So that is the whole question.
Yes, sir.
But if you say, okay, this is in between the non-classical and this is a much milder form of simple virilizing, that is there. So these all possibilities are there. But if I go by your history, there seems to be a long drawn process which is acquired. So history gives you an acquired form of hyperandrogenism and which has now increased. So one is whether there is some adrenal thing which is happening, but it can't be carcinoma because it is a long-standing history. And second could be whether it is hypertrichosis.
Hypertrichosis. Yes, sir.
Carry on.
When we do the investigations, we found all this electrolytes and the screening were normal, and we found that the testosterone was very high. It was 14.74 nanogram per ml, which was very high.
So what does it tell you? Have you seen that level of testosterone
So if we
in a male also?
no, sir, it is like very high for even for a male also.
So 14.74 is 14,000.
14,000 nanogram per
day.
DL.
What is the normal female range?
Sir, it is less than 1. It is 1.7 around
Less than 50.
55.
Less than 55 or 0.55. So it is 30 times higher as compared to a normal female. The normal male range is 180 or 200 you can say, to around 800. So this is much more than a male. So in fact, when I saw this report, I said this is an error. You might have written that this is 0.14 and 1.4 or something. So we got the testosterone done again and then they said more than 15. So this is a very, very significant thing again, which is telling you that something is there which is producing very high testosterone. We have seen so many cases of CAH, we don't see this level of testosterone. So this is very, very high, something to worry about.
And the USG of the uterus shows normal ovaries, so it has
what does it exclude?
a hypertrichosis. It has rule.
If there is hypertrichosis, ovary will be huge.
Huge, bulky.
To produce this amount of testosterone, you need all theca cells, all LH induced production. So that also is unlikely. Now, what's also interesting is that the LH FSH level, what do you see?
So it is not
suppressed.
suppressed.
So if it was an ovarian testing with that much
It
production
has
of
suppressed.
androstenedione and everything, LH may have got delayed to something at that point of time. So carry on.
So we have repeated the testosterone as sir has said, and it was again greater than 15 nanogram per ml. And the 17 OHP was 9.36 nanogram per ml, which was borderline high. And DHEAS was very high. It was it was greater than 1500 microgram per DL, which was far greater than high, which we
Again,
said.
we have never seen that sort of a level of DHEAS. So what we are looking at is there is something which is producing huge amount of DHEAS. Obviously, adrenal is producing, causing this testosterone is a product of that. Now, this 17 OHP, do you think this 17 OHP can explain this level of DHEAS?
No, sir. So because this 17 OHP is in the range of some non-classical CH, but in non-classical
or
CH,
not. So what is more likely, Simon, in this?
Something which is autonomously producing.
And the 17 OHP is a byproduct. It is not a block. See, its main product is DHEA. If you have adrenal tumor, main product is DHEAS. It is peripherally converted to testosterone. But if you are producing the main product at a high level, all the initial products may also go up a bit. So this goes more in favor of an adrenal tumor. And if you allow me, I will say, if you forget about the history, this is adrenal carcinoma. Typical. If I have to think one thing, I will think of adrenal carcinoma. The only thing was, as you pointed, it was a long-standing history. So now we carry on.
So we have a lean female with hyperandrogenism of FGS21 and slowly progressive virilization with very high testosterone and DHEAS. So the most probable diagnosis we have is the 3-beta HSD deficiency due to the very high DHEAS level and borderline
That is also an important
possibility.
to think of. Now, if you think of 3-beta HSD, it can explain lack of a significant hyperandrogenism at birth.
Yes, sir.
But then why is testosterone so? Can testosterone be so high in 3-beta?
So
What is the typical testosterone in 3-beta?
So it is not actually
Very high.
The peripheral production of
Yes, sir.
If your testosterone is more than 15, why would a male with 3-beta ever have DHD?
Yes, sir.
If males have DHD because testo is high. It is like maybe 80, 100. It doesn't reach even 150, otherwise males will be normal. So a 3-beta goes off here only.
Yes, sir.
Because you cannot have this high level of testosterone in 3-beta.
And non-classical CH, as you have mentioned, the degree of severity of virilization is present in this case, and the level of testosterone present in this case not correlating. And adrenal tumor is the most likely possibility here because of the very high testosterone and the very high DHEAS and the presence of the virilization. But this is very slowly progressive, so here is a carcinoma less likely.
You can think of something which is there right from birth, but which is now causing something to suddenly go out of control. Something which is there, which is predisposing to something. So some congenital cause which is now causing a new thing, new phenomena which is really gone up. So that is something you can hypothesize. But again, you have to work out from it.
Now we get the adrenal imaging done, and we found.
Just once again, if your testosterone is so high, why is there no radiological sign?
Cannot be, because after 12 weeks, there is no behavior.
So it is postnatal
Postnatal
exposure, which is very, very clear.
So when we get the adrenal imaging done, we found a very big lesion, adrenal lesion in the right side. And the radiologist mentioned it is a 11.3 centimeter in size, and there are few areas of calcification. And they have mentioned it as a adenomyolipoma.
So what are these findings? When you say it is 11 centimeters,
so
CT attenuation constant is solution is
minus 16.
Hounsfield. What are the
Hounsfield. So minus 64 Hounsfield. It is more. It contains more of a fat. So
if it is negative, it is a lipid content.
Lipid content.
And what about the attenuation? The contrast washout value.
So the contrast washout. It is this. 47.
So what did you discuss with the radiology?
We actually said that it could be still even adenoma also because there is some also this 60 and 40, so which is suggestive of high water.
So basically, what is important there is that there are 3 contradictory findings.
Yes.
One is the size.
Size.
Generally, we say that if the size is more than 4, you consider it as malignant. Even if it is not malignant, you have to go for surgery. That is very clear. Second, if you have a negative Hounsfield unit, it means there is a lipid. So lipoma. The third is contrast washout. This is a bit of a confusion. So this means that there is some adenomatous tissue also there. That is why they have used the term adenomyolipoma. It is not synonymous with myelolipoma. Myelolipoma is a different thing altogether. So there is some adenomatous tissue there. The question is whether this adenomatous tissue is producing all the testosterone, which theoretically may, because 11 is a big tumor.
Yes.
Even if a small area is producing your this thing, you will have a high. The other big pointer here is that this is a monoclonal tumor.
Yes.
If it is a tumor, it is not producing any cortisol.
Any cortisol.
So if you have any cortisol production, you should have had pushing features also, which are not there. So carcinoma usually will have a disrupted steroidogenesis. You will have huge amount of steroid precursors which will come up. You will have greater production of the androgens, DHEAS along with the cortisol. So there is lack of pushings.
Yes. And
a normal cortisol means it's monoclonal. Now, what I'm trying to say is that this is a large lesion. A part of it has got lipid, a part of it has got muscle, a part of it has got the glands. And that glands are producing only one type of hormone which is causing it. This is the more logical explanation there. But we have to work out, of course. But I think this is very interesting scenario. So normally we say virilization is equal to carcinoma. But here, 8 years onset, only DHEAS elevation, and do not have other features of malignancy. So it is, you have to question this as a possibility.
So it could, sir, could it be due to a simple virilizing that has been missed, and should we have to differentiate it from the tumor or the simple virilizing?
So there are two things. So theoretically, you can say that if you have a simple virilizing form which has now caused the tumor, that's what you see.
Yes, sir.
Because of a persistently high acid base level, which you said there is pigmentation also.
Exactly.
So for that you can consider. So, but that is not the cause of virilization.
Okay.
If it is a simple virilizing form, it is not causing the. You are saying simple virilizing form.
Yes, sir.
Simple virilizing, you could have got the labial fusion also. So that is not the cause. This thing is now causing virilization.
Okay.
So even if it is a secondary phenomenon, this tumor is the main cause which we have to remove first. Now coming to your question, if it is CH, whether we give steroids, you will have to give steroids if you are treating this patient once you are removing the tumor. Anyway.
Because of the size is so large, so surgery is planned for this case, and we'll let you know what the biopsy.
This just came couple of weeks only.
Okay.
Carry on.
So we'll let you know what comes in the biopsy. So that's it. So actually, this is for just the comparison. So it is a case of the 9-year-old girl, and she came with a clitoromegaly, voice change, and increased body hair. And there was no history of craving for salt and no history of maternal virilization. And on examination, she also has clitoromegaly of 3 centimeter and pedal stage 1. And on examination, what we found, her 17-OHP level was 136, which was very high in comparison to the previous case. And her DHS level was 207, which was far less than the previous case. And her testosterone was very less in comparison to the previous case.
So let's put it in perspective. So this again is a male level testosterone. We are comparing with 1400, 212 is very significant. But what you are trying to say is that if you have a testosterone of 212, your DHEAS will not be more than 12.
Yeah, exactly.
And your 17 OHP has to be very high, even in the primary CH. This is a known case of CH. This is just to put a perspective.
Yeah.
That there was a debate amongst us whether this 17 OHP is causing the virilization. It cannot. Because here you can see for a testo of 212, your 17 OHP is in hundreds. So it cannot be compared with this scenario.
Actually, there is just a comprehensive view of adrenal myelolipoma. And 440 patients were analyzed, and what they have found that in 44 patients, CH was found in 10%, and 6 were salt wasting, 3 were simple virilizing, and 3 were non-classical. So, and among them, some presented with the primary aldosteronism, and some presented with just the androgen secreting tumor. So there is another case report supporting the evidence that the adrenal myelolipoma associated with the hyperandrogenemia. They showed that there was a 34-year-old Chinese woman which presented with virilization, and she had a very increased level of plasma testosterone and DHEAS, and she was also the known case of CH. And on the surgery, what they found that there was a adrenal myelolipoma in this case also.
She was a known case of CH.
Yes, sir. They have written. So it was written. And in this case, the plasma testosterone was this 2.4 nanogram per ml, and DHEAS was 968 microgram per ml.
What we are seeing here is that you have got an adrenal lesion. I'm not sure, they haven't mentioned anything about CAH here.
Yeah.
But this is a pure case of adrenal myelolipoma. That's why cases they haven't found a case till now in the reported list.
Yes, sir.
Very high DHEAS
and
very high testosterone level. Not very high. So our case may be similar to this. But when they are saying myelolipoma, it means there has to be, it can't just be a myelolipoma, there has to be a tumor producing cells as well, which are producing adrenal.
Yes.
So this is a similar to our case. That is good.
So what we can do, whether it is just adenomyelopoma on its primary origin or whether it is secondary to a CHA. So what we can do a dexamethasone suppression test in which if it is a primary, it will not be suppressed. And if it is secondary to CH, this 17 OHP level will be suppressed.
So we will measure ACTH and DEXA suppression.
Yes, sir.
Ultimately, he will require a surgical intervention, which is there. So I think this is a interesting and a confusing case. The key scenario is that this case is basically presenting a later onset of hyperandrogenism, long-standing hyperandrogenism, significant virilization, extremely high testosterone, extremely high DHEAs with not that high 17 OHP. There is a big tumor, so you have to remove that tumor. If you go by any way, more than 4 centimeters, you have to remove. Functional tumor, you have to remove, so you will remove the tumor. When you remove the tumor, you will also have to give steroids. So this is pretty much the treatment will be the same. Before that, we can do a DAST just to make sure the functionality of it, and we can do a ACTS to identify that. But ultimately, my diagnosis will be similar to that lady, 34-year-old, similar to our case. She started around 2022. She also presented and started at that time. So the key message is that if you have hyperandrogenism with pigmentation, with early onset, with variable presentation, with virilization, always think of adrenal cause, get a DHEAs, get a cortisol, and get a 17 OHP. Mostly you will get the diagnosis. If DHEAs is very high, imaging is essential. Always be wary of 3 beta, FAH, 21, and adrenal tumors in that perspective.